When examining the placenta after the delivery of a baby, the edges of the membranes can be seen. The membranes form the amniotic sac, which contained the amniotic fluid, and the fetus, which passed through this hole during the delivery. The umbilical cord, which connects a baby to the placenta, has 3 vessels. The number of vessels are best counted on a clear-cut area of the cord. Here are the 2 arteries through which the blood of the fetus is moved to the placenta. There may be only 1 artery present, which is not lethal to the fetus, but it should be recorded in the notes. The umbilical vein transports the blood from the placenta to the fetus and is essential to fetal survival. It has a much larger diameter than the arteries. The vein and the arteries are surrounded by a loose gelatinous substance called Wharton's jelly. This protects the vessels and gives the umbilical cord its characteristic appearance. At term, the cord is an average length of about 55 centimeters. Normally, it inserts centrally or slightly eccentric and directly into the placental disc. From here, the vessels have a centrifugal distribution. When lifting up the cord, the fetal side of the placenta and membranes become fully visible. At the periphery, the membranes are inspected for any aberrant vessels, which would indicate a second lobe of the placenta still being inside the uterus. This could lead to a postpartum hemorrhage or to infection. Here, a closer look at the placental margin. The veins and arteries distribute into smaller and smaller branches without any blind-ending vessels in the periphery. The placental membranes consist of 2 different layers. The layer facing the amniotic cavity is the amnion, and the outer layer is the chorion. When pulled apart, the amnion on the left side, where the examiner's fingers are, is separated from the chorion on the right side. Under normal conditions, the membranes are translucent without any discoloration. Following the examination of the fetal side, the placenta is turned over to look at the maternal side. The normal placenta at term is a disc-shaped organ which is fairly symmetrical. It is 2 to 4 centimeters thick and has a diameter of about 20 centimeters. The surface has a maroon-red color and is divided into lobules called cotyledons. They need to be examined to make sure that there are no gaps, which would indicate a missing cotyledon. The membranes appear clear and normal. They are followed all around the placental edge and inspected for any abnormal color or clarity. In the following, a number of placental pathologies are demonstrated, which include cord abnormalities, membrane abnormalities, and maternal surface abnormalities. Examination of the cord gives information about the growth and activity of the fetus while still in utero. Here is a cord with a reduced amount of Wharton's jelly, known as a flat cord. If the diameter would be less than 7 millimeters, it would be defined as a thin cord which has a compromised blood supply. In this case, a marked varicosity of the umbilical vessels is present. They contain blood clots, which could have been caused by compression of the cord due to prolapse or head compression. Another etiology is fetal hypercoagulation due to sepsis or thrombophilia. The vessels are dilated and the presence of thrombi is abnormal, requiring further investigation. Not infrequently, umbilical vessels can form bulges known as false cord knots, which are of no clinical significance. The vessels seem to leave the normal outline of the cord, followed by re-entering the tissue. The occurrence of a true cord knot is more likely if the umbilical cord is longer than 50 centimeters. It should be recorded if the vessels on one side of the knot are more congested than on the other side, which would indicate a notably tight knot. This is a case of a lateral cord insertion, which is a variant to the central or slightly eccentric insertion. The vessels from here spread evenly into the rest of the placenta. In fewer than 10%, the insertion of the cord can occur at the margin of the placenta, which is referred to as a battledore placenta. The vessels, when entering the placental tissue, are not protected by Wharton's jelly. If the placental end of the cord does not enter the placenta normally, but consists of vessels surrounded only by fetal membranes and no Wharton's jelly, the condition is called filamentous cord insertion. Because there is no protection, these vessels are prone to compression and rupture. Rupture can easily occur when the umbilical vessels are located in the membranes covering the internal cervical os, then known as vasa previa. Filamentous cord insertion is associated with fetal growth restriction, prematurity, and congenital malformations. In the following, abnormalities of the membranes will be demonstrated, which may become noticeable during the examination of the placenta. While normal membranes should be smooth and transparent, thickening of the membranes may represent an embryological variant of remnant decidual tissue. The condition needs to be differentiated from chorioamnionitis. This specimen illustrates an example of a subchorionic hemorrhage. Furthermore, the surface of the umbilical cord shows a yellow-green discoloration, which is due to meconium. In the same way, the meconium-stained membranes indicate that the fetus at one stage of the pregnancy must have been under distress, causing the passage of meconium into the amniotic cavity. Here are two large opacified areas which require histological examination for further assessment. Small white areas are quite common and could be caused by subamniotic yolk sac remnants, fibrin deposition, or infarcts. This is a small term placenta compared to a normal placenta weighing about 500 grams. Here is a placenta with an abnormal location of the membranes. The condition is known as circummarginate insertion, which is identified by the membranes coming off the placenta before they reach the margins of the placental disc. The condition is not associated with any adverse outcome. The following demonstrations concern abnormalities of the maternal surface of the placenta. When examining the placenta, it is important to ensure that all cotyledons are present. Here, a gap becomes obvious, indicating a missing cotyledon, which could have been torn off during the delivery of the placenta. If not removed, this piece of tissue could stay behind in the uterus, causing postpartum hemorrhage and infection. In this case, dark blood clots appear through the turned-over membranes, indicating abruptio placentae. When lifting the membranes, the clots can be seen adhering to the placental edge and adjacent membranes. This is a sign of a marginal abruption. There are even more clots which become visible when the membranes are turned over, some in the central area and a large one at the opposite placental margin. The clots are almost black and organized, which means that the abruption must have happened a while ago. Here is an example of a large abruptio placentae. The size is defined according to how much of the placental disc is covered by blood. In this case, the abruption takes up over 60% of the placental surface. When removing the clots, the indentation into the placental tissue can be seen, which means that the clots must have been present for quite some time. During the third trimester of pregnancy, the observation of calcifications is a normal part of placental maturation. It is found to occur earlier in smoking women. On palpation, the affected areas have a firmer consistency compared to the normal placental tissue with its softish, spongy touch. Calcifications in the second trimester are abnormal, indicating possible placental insufficiency leading to fetal growth restriction and fetal distress. The appearance can vary widely and may show only isolated spots, as illustrated in this example. Here are calcifications and infarcts, which look similar. When cutting through calcifications, they are more superficial, while infarcts sit deeper. Furthermore, there is a hematoma present. This is a grossly abnormal finding, which illustrates a placenta of an intrauterine death. The tissue has an increased thickness and contains a large amount of calcifications. There's a greenish discoloration, and when lifting up the membranes, typical meconium staining becomes visible. The cloudy, opacified appearance suggests chorioamnionitis, which is supported by the foul-smelling odor during the examination. Furthermore, there are blood clots and fragmentation of the placenta. In the following, the placentas of twin pregnancies will be shown. The placentas of twins can present in various forms. Here are dichorionic diamniotic placentas, each one having its own umbilical cord, which inserts more or less centrally. When examining the membranes, one can see how they divide the two placentas and separate them from each other. One set of membranes is allocated to one of the placentas, and a second set of membranes to the other placenta. The placentas are now turned over from the fetal side to the maternal side. The membranes, which are turned inside out from the amniotic sacs, are moved out of the way to gain access to the surface of the two placentas. By spreading them apart, it becomes clearly visible that they are two separate individual placentas linked to each other only by membranes. In this twin pregnancy, there is only one placenta with two umbilical cords, which show multiple knots with cord entanglement. This is only possible if both twins share one amniotic sac. Following the cords down to their insertion points into the common placenta, it becomes noticeable that there are no dividing membranes present, indicating a case of monochorionic monoamniotic twin pregnancy. When examining the distribution of the arteries and veins as they come from the umbilical insertion points, it is possible to follow the branching until the appearance of anastomoses between the vessels of both cords. These vascular connections can be identified at a number of places. The vessels of both cords derive from different directions, and while spreading through the tissues, they converge and form anastomoses. The umbilical cords are lifted, and it is once more demonstrated that the inverted membranes only formed one amniotic sac. There is no membrane which could have separated the twins from each other. On the maternal side, there is only one placenta with a single disc. Inspection shows a complete set of cotyledons and a normal surface. This then concludes the demonstration of various placental findings.